Hi everybody, morning, and congratulations on making a great choice to come to this fantastic session. About 300 people signed up for this session, and I guess there's 70 or 80 people here. And so we're just going to wait a few minutes, if that's okay, to see if some more of the people who've signed up find their way across to the outer reaches of the venue. But I can promise you that you've made a wonderful choice and you're going to have a fantastic hour and a half.
There's no pressure there at all, real lucky where you put your Yeah, I've got to come around the world, do multiple things at once. So I was in Singapore, in Geneva, and it's a huge investment time.
What did you do in Singapore?
Talking to the Singapore government about some foresight work I'm doing with them. So looking at, there's a team in the Prime Minister's office looks at where Singapore's going long term.
Yep.
I'm working with him.
So we're just signing up to provide them with support around clinical leadership development. And we were meeting them here yesterday about the kind of getting the shape of that organised.
What's fascinating with Singapore is so the people in the PM's office I've been dealing with have said, if you're working in health, why don't you talk to our health people? Our things around bottom-up empowerment. I'm like, yeah, I don't.
Yeah.
You know, I'd sort of like push it to
Bottom-up empowerment in Singapore is an interesting concept.
Yeah, it's an irony, isn't it? So I've sort of avoided that.
Look, as the time's moved on, I think we'll make a start. So, welcome to this session on strategies for transformation from across the globe. We're going to hear from two extremes of the globe, from Saskatchewan and from New Zealand, and the order is going to be a reverse of what's on the program. So Bonnie from Saskatchewan is going to start off by introducing the approach to high energy change that they've introduced in Saskatchewan. Bonnie.
Well, good morning, everybody. I want to start with saying what a privilege it is to be at my first International IHI Forum and to be sharing experiences with you and the other 2,800 people that have joined us. It's quite a story, and I'm going to start with my story first. I'm the CEO of the Health Quality Council, and I'm 4 years old in terms of being a CEO. And I must admit, it has been and continues to be the most humbling experience of my life. And not only is it humbling, but it's considerably rewarding. And when I'm not the CEO of the Health Quality Council, I'm the mother of 3 sons. And this is one of my favorite pictures of my sons because it really is the quintessential Saskatchewan photo. So Saskatchewan is known for its vast landscapes and its prairies. And this picture was taken a handful of years ago when my boys didn't talk nearly as much as they do now. And I don't know, for those of you that are parents, this is one of those pictures where they just look so happy and so joyful. But the reality to get this picture taken was quite another story because the wheat is very scratchy and there was bugs and there was mosquitoes and everything else. So there was a lot of angst to get this picture done. My tallest son, Matthew, he's my oldest. And Matthew was diagnosed with autism spectrum disorder, and he also has a moderate developmental delay. And certainly those opportunities have introduced us to how to link not only a healthcare system but with an education system. But what Matthew has given me and my husband and our family is a lot of insight. And recently, a couple of years ago, Matthew was diagnosed with cyclical vomiting syndrome. And cyclical vomiting syndrome, in layman's terms, is an abdominal migraine. And it's a chronic condition that, without a lot of advance notice, he'll start throwing up and he can't stop. And so what this requires is then emergency visits and et cetera, et cetera. But the reason why I'm telling you a little bit about Matthew's story and my story is that, you know, we've been blessed with good health in my family, but now with the introduction of a chronic condition, this is where we've really seen how unsystemed the Saskatchewan healthcare system is. And it's given me a very rich perspective and a humbling perspective because I'm not a clinician. I'm a health economist by trade. And often I find when I'm in conversations, I hold myself back and say, well, what can I offer to this solution? Because I don't walk in the shoes of clinicians, but I walk in the shoes of a parent with a chronic condition. And I think that gives me strong voice and clear voice for what needs to be done in our healthcare system. So again, my thanks for you for letting me share my story. And now I want to share the story of the province of Saskatchewan and our early journey so far in trying to transform our healthcare system. And hopefully with this story, there might be some ideas or insights that might be helpful to you, because again, I think that's the most wonderful gift this forum gives us, is the opportunity to share and learn from one another. So why Einstein? Well, I think it was because a number of months ago when asked to submit an abstract about our story in Saskatchewan, we were doing some word mapping and thinking about what we were doing, and the pace, like I'm sure for all of you, seems frenetic. And there's a lot of energy that goes with a very unwavering pace. And so as we were word mapping, we were thinking acceleration. What do you need to do to accelerate? Well, you need energy, transformation, energy, and everything kept back to energy. So I felt it would be kind of fun to show how energy can be generated and must be generated to transform an entire healthcare system. So there we are, the country of Canada, and where I come from is the province of Saskatchewan. And I often joke that Saskatchewan is an Aboriginal word for trapezoid, because our boundaries are so lovely and straight, but that's definitely not true. But Saskatchewan is in the western part of Canada, about an hour's plane ride from Calgary, in the east direction. Saskatchewan, in terms of land mass, is about more than 100% the size of Sweden, or it's in other words, it's bigger than Sweden by just a bit. But we have 1 million population across that geography. So from a density point of view, we have about less than 2 people per square kilometer. So it is quite different from where I am today in terms of population density, and that geography introduces some interesting challenges. As I referred to in my introductory comments, we're primarily known as an economy that's agriculturally based, but of late, our natural resources, particularly potash, have moved our economy from one of a have-not province, as we refer to it in Canada, to being a have province. And so that is changing the ambition and I think the energy again in our province in terms of having the abundance that we now have. There was conversation in a session I was in yesterday about Canada's national health system. And for those of you that may not know Canada well, healthcare is primarily a provincial jurisdiction. So each province has primary responsibility for the funding and delivery of healthcare. That's not to say we don't get funding from our national government. We do, but those transfer payments have gone down considerably over time. And I think that's part of the reason why there isn't a national health system, if you will, in Canada like there is in other parts of the world. And so again, my story is from a provincial context, because that's where you're starting to see the change. And what's unique in Saskatchewan, I believe, compared to my counterparts across the country, is that we have set our ambition so that we can completely transform healthcare for the entire province, not for a hospital, not for a health region, but for the entire province. So a very brief history in terms of our healthcare system. Being a publicly funded health system in Canada, most jurisdictions will fund their health system through their taxes, and Saskatchewan, I think, was one of the first jurisdictions to introduce a taxation system and to collect taxes for hospital. Another notable time date was 1947, where we introduced the Hospital Insurance Act, which allowed people to access hospital care without charge. But probably what we're most known for in Saskatchewan is the fact that our province, through our premier at the time, Tommy Douglas, introduced publicly funded health care. And that legacy is one that Saskatchewanians hold very dear to their heart. And actually all of Canada, and Tommy Douglas was named just a couple of years ago the most famous Canadian ever. So we're very proud of our publicly funded system. And while we're very proud of that history, I think finally, in the last couple of years, we've moved from pride to unrest, because sometimes when you are very full of pride, it allows you to sit on your laurels. And I think that was our state of experience in Saskatchewan a handful of years ago. Oh, we've got one of the best funded health systems. We can provide 100% access. Just look at our neighbors to the south. You know, what would you prefer? But with more careful and closer scrutiny, we've determined, and thankfully, that we have lots of room for improvement. So here is a map of the province of Saskatchewan that's organized by healthcare delivery systems. And it is currently a very busy map. But believe it or not, more than 10 years ago, the map was quite busier. there was actually 32 distinct regions in our province that were responsible for delivering and organizing healthcare. But right now we have 13 what we call regional health authorities. So those shapes in this province are responsible for the majority of healthcare services in the for the province. Health promotion and prevention, acute services, mental health services, community services, long-term care, home care services. The only service that's not under the jurisdiction, if you will, of a regional health authority is our medical services. So our physicians, who are predominantly fee-for-service, who are paid by the provincial government, work in parallel with this regional structure. And I just would ask that you kind of keep this picture in your mind as I continue to tell my story, because 10 years ago, the way we thought about healthcare and healthcare improvement was very much a menagerie of the efforts and the intentions in each and every one of these health regions. So in 2002, there was some foresight done by a commission on healthcare in Saskatchewan, and the creation of the agency that I work for, the Health Quality Council, came through. And again, it was because Saskatchewan was now starting to appreciate that our challenges were not that different from many of yours. We were having an aging population. Our First Nations population was growing rapidly. We were starting to see lots of chronic diseases, particularly in our First Nations population, but also in our non-Native population. And there was this agitation that was starting in the system that said, I think we need to think differently about how we deliver health care, and our focus should be on quality. So we were delighted to be the first in Canada to be created, and we're still relatively unique. Since the Health Quality Council was created, there have been, I believe, five other jurisdictions in the country that have established councils like mine that have varying mandates. But our mandate at the Health Quality Council is to measure and report on the quality of healthcare in the province, and to support and work with those in the health system to improve quality. So it's a lovely dual mandate because it offers the opportunity not just to talk about what the improvement needs to look like, but actually working with people in the system about how to improve it. So this is a very well-known schematic, and I updated it from my slide presentation notes that you have. And it was of interest to me when I updated it a couple days ago that when you look across this matrix, that Canada has actually improved in terms of its health status, that bottom row, long, healthy, productive lives. The slide that you have in your notes indicates that we were number 3 a couple of years ago, and we're number 2 now. And I've heard, and I agree, one of the most fundamental outputs of a high-functioning healthcare system is better health. So there's some good news, I guess, in this schematic, is that Canada, thankfully, is doing well when it comes to the health of its citizens. The bad news side of this slide, if you will, is that when you look at how we deliver care and how we ensure whether care is safe, timely, effective, efficient, and equitable, we're not doing very well. So it's a bit of a mixed story. And I would argue to you, or offer to you, that the reason why I think we're doing so well on the health side of the equation is really a factor of our public and our social policies, both within and beyond health, and very much a determinants of health model, which has been around in Canada since 1971 in the Marc Lalonde white paper that was written on the determinants of health and looking at those other pieces that can influence health. But this slide continues to garner a lot of attention, and although earlier editions have been around, what that offered us in Saskatchewan, again, was this sense of agitation. Maybe we're not as good as we think we are. So as I mentioned, Health Quality Council has a role to measure and report on healthcare in Saskatchewan and the quality of healthcare. And the first 5 years or so, we did a lot of reports, and these were one-off reports. And we were very deliberate that we didn't focus in one particular area, one particular chronic disease, because we needed to show, or we were hoping to show, that the opportunity for improvement was across the health system. And each and every one of the 15 reports that we released in our early years indicated lots of room for improvement. But as I mentioned, we didn't stop there. We went from reporting and measuring to actually then working with the providers, the health administrators, the bureaucrats, everybody that is involved in organizing and delivering healthcare around how can we improve or narrow the gap between current practice and ideal practice. And this slide is essentially just the schematics of the many improvement capability programs that we have offered over the handful of years, starting from 2002 to about 2008. But the problem with this approach, as we realized 5 years into the game, is that we were really just chipping at the margins. So what we were seeing is pockets of excellence emerge in the province, but this gnarly thing called spread was eluding us. And very sadly, there wasn't that connectivity across the province in terms of if something was going well in the southwest corner, why couldn't we transfer that to the northeast corner of the province? And if our ambition is the highest quality of healthcare for everyone every time, particularly from the Health Quality Council's point of view or from the government's point of view, the best health for Saskatchewan citizens, what could we do differently? And so we stepped back and we consulted with our partners, those working in the health system, about how we need to go forward. And this is a great quote that recently I picked up from Mats Bostig from Jönköping when I had the privilege of being in Sweden last month to learn from them and their Microsystems Festival. He said this, and I thought, well, that's exactly what we were trying to do a couple of years ago. We need to change the outcomes that we're seeing, and to do so, we need to change the way we actually do things. So the Health Quality Council went to the literature, and we went and said, well, who's kind of case this? What systems have demonstrated a fundamental redesign or transformation of their system? And so we were very, very intentional to learn from high-performing, innovative systems. And what you see on this slide is an example of the ones that we learned from. And what I mean by learn from, we grabbed everything that we could read in those early days. We would email them, we'd phone them and ask, can you share your story? Can you help us understand what are the key facets of moving from pockets of excellence to a system that's completely transformed? And from those conversations, they offered some attributes, and the attributes are becoming more clearly defined now that we're in 2011 in terms of what's required. And now as I look at this slide, which was actually generated about 4 years ago, it's a bit of a different way of presenting a driver diagram. So our ambition was accelerating excellence. How could we accelerate the best possible evidence, the best possible care across the province as fast as we possibly could, that center box? Well, our primary drivers were, we need to engage clinicians, we need to improve or build organizational improvement capability. You have to have a measurement system, a measurement infrastructure, because what you don't measure, how can you manage it? And without question, there had to be leadership development. This was requiring a new way of leading. So those colored boxes were our primary drivers, to use driver diagram speak. And then the smaller boxes were then our secondary drivers, some ideas that were either already in place or things that we thought about implementing over the years ahead from about 2007 on to approach transformation in Saskatchewan's healthcare system. So back to Einstein's theory. So it's my feeling that energy requires many people, that we weren't going to do this in a cave with a few people saying this is how it shall be. And certainly we needed to have commitment and collaboration. So those were the themes that really characterized those early days over the last few years of what we needed in terms of some of the early signs of transformation and experience in transformation. So in the context of many people, commitment and collaboration, I want to focus on clinician engagement. And clinician engagement was very intentional. And it was very intentional because at the time, in our province's history, we had just come out of a very acrimonious nursing strike. And the negotiations were quite intense. And, the nurses had finally agreed to a new settlement. But regardless of having the opportunity to earn more wages, there still was a disquiet among the nursing workforce. They felt that they weren't empowered to make the decisions that they needed to provide safe, reliable, patient-centered care. Well, lo and behold, again, through some of the stories and some of the experiences that we were gathering, we learned of a wonderful program called the Releasing Time to Care, the Productive Ward program coming out of the NHS. And they were 18 months to 2 years into this program, and we had gotten wind of it, and we thought, what if we look at this program and think about this program in Saskatchewan as building will and opportunity and capability for the 9,000 nurses that are working in our health system. And so we embarked upon the Releasing Time to Care program. And for those of you that are not familiar with it, it's you know, and I hope I'm not wrong, but it's not dissimilar to the Transforming Care at the Bedside program, where you offer tools and capability to teams, those nursing units, that allows them to improve patient outcomes, patient safety, patient experience, workplace experience, and efficiency. But it's giving them the power and the time to make decisions and to understand what their systems look like, and the opportunities to redesign their processes. And we thought it had a lot of merit. So the next few slides are just pictures of what we've accomplished so far. And now, 3 years later, we have implemented the Releasing Time to Care program in 52 nursing units in the province. And so what that means is that over a third of our acute care beds are now licensed for Releasing Time to Care. Now, sometimes there's a viewpoint about, well, you know, once you've finished all of Releasing Time to Care, you're done. But it's like improvement in general. Releasing Time to Care will never end. It is a way of doing, it's a way of thinking. And for us, it has offered a wonderful, wonderful opportunity to engage the nursing community and the communities of people and health providers that work on the units in the hospitals in Saskatchewan about redesigning their work processes and the way they deliver care. So as those of you that may know the Releasing Time to Care program, one of the key things is understanding the work that you're doing and the results that you're getting. And this is an example of a board, knowing how you are doing. And you will see a data wall like this on any nursing unit that is doing Releasing Time to Care. They won't look identical, but the essence of them is the same, where there is that intelligence and metrics around how patient experience is improving, what safety looks like as demonstrated by a safety cross, what's workplace experience, and it's on the walls in the wards for everybody to see. Another key foundational model to the Releasing Time to Care program is the well-organized ward, or we call it WOW. And WOW allows us to understand how to reorganize a ward to make it more efficient and effective. Because the research has shown, and RTC has demonstrated this, the Releasing Time to Care, is that on average, anywhere between 28 and 35% is the average time that a nurse spends on direct nursing care. And the reason why it's so low is because they're hunting and gathering for supplies, they're spending time on transitions, they're doing administrative work, and the time that they want to spend with patients is sorely reduced. So what we see in a lot of the units that have embarked upon Releasing Time to Care, obviously, is the work on the foundational models to reorganize their wards. And so here was a lovely supply room in one of our larger hospitals in Regina, Saskatchewan, which has a population of about 250,000. And that's what it looked like before Releasing Time to Care and the unit working on the well-organized ward. Well, that's what it looks like now. And again, it's more than just a tidy. It's everything in its place and a place for everything. So think about that. You know, when you can find what you're looking for without having to search for it or run down a hall or go up to another floor even, think about the amount of time you can save and redirect it to direct nursing care time. And this is one of my favorite pictures because this was an interesting little story. This was in a medium-sized hospital in a more rural community. And, you know, look at that, over 1,000 kilometers per year of steps were saved because of the creation of that door. This hospital is about 40 years old, and for 40 years, there was no open way between these two rooms. And with Releasing Time to Care and a study and inquiry into how their ward was organized, the nurses said, well, what the heck? Could we not, you know, blast a door through these two rooms? And the old culture would have been, well, you have to go up 7 steps, you know, 7 layers to get that decision made. Well, why even bother? Well, Releasing Time to Care took those 7 steps to 1 step because there was the support and sponsorship from the leadership community for this program. And so the creation of a doorway saved a lot of footsteps. And what this slide shows is, again, some of the tools that are available in Releasing Time to Care and a spaghetti map of how nurses and licensed practical nurses would travel for things like IV pumps and other supplies previously to how they do it now. And their savings on this particular unit was 13 nursing shifts per year. Recently, a slide was generated from one of the units in Saskatoon, again, one of our bigger centers, that showed mealtime. And this slide might be a bit hard to show, but essentially it was just how they reorganized the way they delivered meals. And it went from an average of over 200 minutes to now to 77 minutes. And look at this. They didn't highlight it as strongly as I thought they could have, but they said we've saved 71.3 12-hour shifts per year. That's more than a full-time equivalent, or it can be. So it's quite powerful. So all these slides, are showing how can you do things more efficiently, in terms of saving time for nurses. But a very critical piece of releasing time to care is improving the safety. And so again, here's a smaller hospital example of how the number of falls have reduced in this setting. And presently their goal is less than 10, but having just spoken to them, they're now taking it down to the next level because they feel that their system is stable and they want to improve the number of falls to even a lower level. So this is a busy graph, but why what's the key contribution, or one of the key contributions to this program is that nursing staff are spending more time with patients. And I'll direct your attention to the set of bars at the very right-hand side of the graph. And our data was no different than what the research had shown previously, that particularly for this facility, direct nursing care time at the bedside was 26% when they started in January of 2009, and it's now at 41%. And this data is January 2010, so it's even a bit old, but some phenomenal improvements in terms of the amount of time that nurses are able to spend with their patients. And in terms of patients' experiences, we're also really seeing some very positive results. And what this graph shows is the improvement that we've seen, again, on one of the units in terms of the extent to which patients felt that they were involved in decisions about their care, growing from 42% back in November 2009 to over 72% in May 2010. And what we're seeing is those sites, those units that have releasing time to care on them, their overall patient experience metrics. And we use the HCAHPS survey tool, the one that has the question on a scale of 1 to 10, how would you rate your experience at this hospital? Those sites with releasing time to care are substantially higher than the overall average that we're seeing across facilities in Saskatchewan. So the evidence is becoming stronger and stronger that this is a program that has a lot of merit, not only from a results point of view, but really critically importantly is the engagement of the nursing staff and improvement. And a very exciting and inspiring story is when we first introduced releasing time to care, there was a lot of fear about judgment and measurement and blaming and shaming. And now, particularly in those units where releasing time to care has been around for 18 months or longer, we're now starting to see those communities ask questions like, well, if we want to make this change, how would we measure it? And why don't we do this? Like the energy and the enthusiasm is palpable. So again, the energy of many can transform a system. This is probably one of my favorite pictures in the slide because I referred to leadership commitment for a program like Releasing Time to Care. Well, the two gentlemen in this slide are, in the middle, my Deputy Minister of Health, Dan Florazone, and the other gentleman is my Minister of Health, the Honourable Don McMorris. And their commitment to releasing time to care is incredibly evident and unwavering. And this slide is of, again, a small hospital of a nursing manager telling the Minister of Health, here's how we've improved on our unit. And I couldn't imagine a picture like this a handful of years ago. And now these pictures are commonplace. And the Minister of Health has told us that these kinds of visits, these kinds of experiences are the best that he has in his life as a Minister of Health. And in our country, in our context, ministers of health don't stay around for very long. But this minister has been the Minister of Health for the entire mandate of this current government, which is hitting its fourth year anniversary, and we're going to election in November. So unlike his colleagues across the country, he's been in this portfolio since day one. And given that abundance, we now have some constancy of purpose with focus on quality. The other exciting work that we're doing in terms of engaging clinicians is how we're engaging physicians in quality improvement. And what's notably different in our story, in our province, is how we've decided to collaborate. Agencies that typically or historically have not worked together have decided if we are trying to transform healthcare, we must work together. And so what you see here are those agencies that have very intentionally decided to come together and design ideas and approaches to engage physicians in quality improvement. Everybody knows, the literature says, that you cannot transform a health system without the active engagement and leadership of physicians. Physicians want to be engaged in quality improvement. And we are now, again, working together to figure out ways to grow and develop our physician leaders so that we can have them at the tables and not repeat the history of the past where they were more on the outside looking in. We didn't think that was anything new or unique. We thought, well, how else would you ever do it? But when we travel to other parts of Canada, we are often told you could never get our medical association in the same room as the College of Physicians and Surgeons, so we don't know how you did it. And sometimes ignorance is a good thing, because my ignorance was, well, how else could you do it if you don't bring them together? So what we've seen so far is over 150 physicians actively engaged in quality improvement. And actively engaged could be participating in some of our quality improvement collaboratives, going on study tours, experiencing the IHI Forum, both in Orlando and internationally, igniting ideas and inspiration among them, and from there, growing them. Very quickly on improvement capability, we have modified our programs somewhat to be more intentional with what the needs are of our health system. And again, these are schematics of some of the things that we are doing. Most notably is we are going very big and very broad with clinical practice redesign in our province. And what that means is very much focusing on building capability for physicians, primary care practices, and specialty practices, and the teams that they work with on advanced access as well as office redesign. So using lean methodologies to redesign processes in offices to improve access and flow. The other really critical piece is building deepened capacity for improvement. And so we've stolen shamelessly from IHI and created our own improvement advisor program. And we often have people like Bob Lloyd, Sandy Murray, Lloyd Provost, and others come to Saskatchewan when we need their expertise to help lead these programs. But now that we're in our third and fourth waves, we're now building that capacity and capability within the province, and our faculty are now more homegrown, and so we're not as reliant, but we were certainly deeply appreciative of the relationship that we had with those leaders from IHI to help us build this program. So our ambition by 2014 is that we'll have the square root of N in our health system in terms of those with a deepened capacity for improvement science. And our workforce population in Saskatchewan for healthcare is about 40,000. So overall, we've hit about 2,000 people, so to speak, in terms of exposing them to improvement methodology, offering workshops, webinars, sponsorships to learning opportunities, what have you. And that's just a beginning. But in a handful of years, we've gone from just a handful of people understanding improvement science to what we feel is maybe a movement for improvement and a focus on quality. So my next play on Einstein's formula is around excellence. And I referred to in my title, how do we accelerate excellence? Well, excellence is a function of having mission, courage, and constancy. And what I'd like to speak to now is particularly around leadership development. And we've heard and we've learned and we've experienced that you can't transform a health system without solid leadership. And it's not just formal leadership, but it's leadership throughout your system. But we recognized in our system that the formal leaders were ill-equipped to think quite differently about how to lead a health system and their organizations for quality. And we embraced quality as a business strategy, which is a model from the Associates of Process Improvement, API, and what Jönköping, Sweden has embraced as a management framework for understanding and leading for quality. And what you see on this slide is the essential principles or aspects of quality as a business strategy. The focus on establishing and communicating purpose for an organization or a system. Why are we here? What are we trying to accomplish? What are our values? Systems thinking and understanding a system, whether it's an organization, whether it's a practice, or whether it's an entire health system, how we need to think about it. Because, the honest truth is the people that use our services just expect us and believe that we actually think that way. They don't distinguish when they leave one health region to go to another. They don't think that the care that they're receiving from their primary care physician is distinctly different or unconnected to the care that they're going to receive while in hospital. They think it's one system. And so we have a responsibility as leaders to view the organization and health system as one. And gathering the information to improve. Like many other jurisdictions, our ability to collect helpful information on improvement was limited. While we are blessed in Saskatchewan with having a very comprehensive set of administrative health data sets, they are helpful, but they're limited in their ability. And how do we need to think about designing and managing a system? Planning for improvement, managing improvement are also fundamental activities of a leader and a leadership community. And you have to be constant in your focus of improvement and what you're trying to accomplish. And these were concepts and ideas that we shared. And so on this picture, what this is a picture of our learning collaborative. So we very intentionally went with an improvement learning collaborative for our leadership community. And we brought over 200 healthcare leaders in the province 6 times over the course of 18 months. And those 6 times were focusing on each and every one of those items that I talked about in the previous slides. In between the workshops, we had very intentional action periods. We said, okay, you've got homework, people. So when you think of core purpose, to what extent, do you have that and have you communicated that? What does your information system look like? And I have to admit, these were the most uncomfortable sessions that I have experienced in my 20 years working in the healthcare system in Saskatchewan. But you know what? They were also the most exciting and exhilarating conversations I've experienced in my 20 years working in the Saskatchewan healthcare system. They were uncomfortable because we were beginning to name the nonsense. We were beginning to become very truthful about what we knew and what we didn't know. And when you have the Ministry of Health, when you have unions, when you have regional health authorities and health provider groups all in a room, it's quite a powerful experience. And so this, to me, is the genesis for where we are today in terms of how we're thinking and acting like a system. And as I mentioned earlier, we stole shamelessly and we begged profusely in terms of getting help whenever we could. And certainly the leaders from Jönköping Health System in Sweden, as well as those from South Central Foundation in Alaska, have been incredibly valuable to us as we begin and are in our early stages of transformation in Saskatchewan healthcare system. And we've relied on those friendships and relationships to guide us and to continue to counsel us on how we're working better for Saskatchewan residents. So while we were doing all of this work, the government was actively working on some of the policy planks that it had when it became elected in 2007. And in 2007, the Premier at the time wrote this letter to all of his ministers saying, this is what you need to do in the next 4 years. And one of the things that the health minister was given was a value for money audit. So it was a line item in his letter. It says, I think you need to do a value for money audit. And we all wondered, what the heck was that going to look like and what the heck was that going to accomplish? But what was so remarkable, and I think a function of the conversations that we were having now as leaders, that quality as a business strategy experience, is what originally was intended to be a value for money audit turned out to be a patient's first review of the health system. A very broad, comprehensive conversation with the people of Saskatchewan about what was working well and even better if in our health system. So there was thousands of discussions with people who use the system or caregivers of the system. There was conversations with those who provide health care. But what was beautiful about it is that it really bookended the beginning of the conversation with people who use the healthcare system, and it ended with people using the healthcare system. And in between was the provider perspective. And from that, we heard the voice of our customer. We heard the voice of the people that we serve. Good. So it was, again, to me, this is our North Star. This is the guide that we now have to respond to and improve our healthcare system based on what the people that we serve have told us. So it is quite exhilarating for me to think of how our journey has changed, or has fundamentally changed from what it could have been a few years ago had we not had the experience of some of the leadership development. What people told the commissioner at the time, the gentleman who wrote this report, is that they hated waiting for care, particularly surgical care. They hated waiting or repeating their story 17 times. I just told my story to this provider. Why do I have to tell it again? They really didn't like it when they were treated with disrespect. And they knew that the disrespect was probably a function of nurses and other providers being too busy to provide the care that they wanted to. But the stories that we heard from the patients and the residents and the clients of our healthcare system were very moving. And they really, again, set us on our haunches about the opportunities to improve the experience. So what came from this patient first review was the first ever major provincial priority, and that's our surgical initiative. Sooner, safer, smarter. Now, those weren't the words necessarily that the people of Saskatchewan told us, but they did say, we want to receive our surgical services sooner. They didn't say they want it to be safer. That's a given. But when they asked about why they had to have tests repeated or lengths of stay that seemed longer than what they thought, that was an expression of safer. And of course, smarter, again, is how can you do things more efficiently. So that's the extent, or that's the frame. And you know what? If you think about it, it's not entirely different from a triple aim kind of construct, right? Yes, it's mostly focused on the care side of it, but you see the cost and the efficiency piece to it as well. So again, a very promising next step around how we're thinking about healthcare and improving it. We've heard over the last day or so the focus on thinking about the entire experience of care, from entry into the health system to when you leave it. So while there was a very focused attention on wait times and getting individuals in for their surgery as timely as possible, the system actually pushed back. When the government said, you know what, we want to ensure that every Saskatchewan resident has surgery within the next 3 months, like within 4 years, within a 3-month time period, the health system said, that's okay, but we also want it to be timely, appropriate, respectful, et cetera, et cetera, et cetera. And this map, this value stream, reminded us that you have to think about all of the pieces. So how have things changed in Saskatchewan? Well, here on this slide is our first ever strategy map using balanced scorecard methodology for the entire health system, not for an organization, not for a health region, not for a health professional organization, but the entire health system. Now, of course, those organizations and those regions have their own balanced scorecard, but now they are nested within a provincial expression of strategy and ambition. Very quickly, measurement infrastructure, a key driver for transforming the healthcare system. What we've done historically were those one-off reports. And then about 3 years ago, we said one-off reports are no good. Let's go with an annual report that starts showing information temporally that will show at a provincial or regional level opportunities for improvement. And while that was okay, it wasn't great either. Well, where we've moved to is, I think, the most transparent form of reporting in Canada on quality of healthcare. And this is our website, qualityinsight.ca, that now shows across 30 indicators that are anchored to the surgical initiative, how we're improving over time. These indicators were developed in consultation with our health system leaders and decision makers, and they now can show comparative analysis by regions across a number of socioeconomic status groups and other demographic information, a very rich database that really, I think, is going to be invaluable to us as we go forward. And these are just screenshots of the things that you can generate. So I encourage you to go to that website, which I think is a very promising beginning. And what's inspired this website, again, was thinking about measurement at all levels, how you need to think about the macro system, the provincial or regional level, the meso system, that in our context, facilities or maybe even practices, and then the microsystem, and how measurement has to cascade both up and down and where suitable, aggregated up and down. Because if you don't have that collective source of information, you can't improve. So the early signs of transformation, as I've alluded to, is we've articulated a common purpose for our entire health system. We're working very collaboratively for priorities, measures, and targets. We have very broadly introduced lean methodology, not only through releasing time to care, but more broadly, we've seen that as a critical improvement and management strategy for the work we're doing. So the focus on process redesign is unwavering. And I think because of these collective efforts and our early days of transformation, we have generated a level of energy that I haven't seen in the 20 years that I've worked in Saskatchewan's healthcare system, an energy that's going to be fundamental for us to transform the health system and ensure that we are providing the best possible care to all 1 million people of Saskatchewan. Thank you very much.
Bonnie, that's fantastic. Thank you very much indeed. We're going to go on to our second presentation so that we can then talk about both of these experiences together. So I'd like to introduce Roger, who's come from Canterbury.
Or New Zealand, maybe. We're just waiting for the presentation screen to switch over. But while that happens, so I'm from Christchurch in New Zealand. I don't have any pictures of what New Zealand looks like, but you may have seen a little movie called Lord of the Rings. And in that movie, there were some lovely shots of what New Zealand looks like and some of its inhabitants. Most of them aren't that tall with hairy feet. Our health system in Canterbury, we have about 8,000 people sort of directly under the control of an organisation called the Canterbury District Health Board, but in the whole health system there are about 16,000 people. So that gives you some idea of the scale of the system in which we're working with. And what I'm talking around today is how we're starting to get some transformation in that system and how we get scale around making some of those changes and bring them to life. With the benefit of hindsight, looking back, it's easy to look at these types of programs and to figure out how they've worked. And with the benefit of hindsight, these are some of the strands that we've identified as being key to the transformational journey. There's a lot of names on this slide around different programs that we've used, and some of them have some of the same characteristics of those mentioned by Bonnie. So, for example, clinical leadership, lean thinking, all those types of things. The one I'm going to talk around is one called Showcase, which appears towards the right-hand side, which we kicked off in 2009. The foundation of this, though, was a program we called Seeing 2020. And that started way back in 2007 when we said, actually, what does the health system need to look like in 2020 in order to be sustainable? What are some of the characteristics, some of the themes, some of the things we need to have happen? Because it was very easy to look down the line at a leadership level and see where the cracks started appearing, where things started to fall over, where care started diminishing, all those types of things. And we need to understand how to get a coherent vision across the system, because as we found that, and you probably find this in your own organisations, people in the system in their various silos already know where the cracks are appearing, they just don't have some coherency around how that looks as a system. We started off with a group of 80, as the name suggests. We got 80 thought leaders and influencers from across the system, and we brought them together for 3 days. This is the CEO at the time addressing some of them. And we said to them, what do you think it looks like? What are some of the characteristics of that system? And we didn't just stick it at health as well. We brought in experts from airlines, from hospitality, from businesses as diverse as courier systems, to bring in insights to equip people with new ways of thinking which they wouldn't normally get exposed to. Because invariably what you find is that in any organisation or any sector, some of the problems that you face will have been solved somewhere else, just in a different type of thinking and a different approach. So it's really important when you look at this type of exercise to bring in perspective some areas you'd never normally expect to look at. This is the group of 80 that we had. There's a whole range from mental health, NGOs, physiotherapists, nurses, surgeons, a whole range of people involved in there. And what we found when we were going through this program with these people was that at the end there was this really large appetite to do something. We felt like we had a tiger by the tail and that these people understood what needed to change, but they couldn't quite get their heads around how they would do it. So during the course of the workshop in the background, we developed what we called the permission card. And what we did, when every individual left the workshop, we gave them a wallet-sized laminated card that said, you have permission to change the system. And there were some really interesting results from that. So the CEO that was on the screen before, Gordon, so he said that a year after one of these first workshops, he was walking down the corridor of a rural hospital, and this woman rushed up to him and started just absolutely letting loose about this change she'd made and how it was fantastic and better for patients and didn't cost much. And he stood there listening to it, and she finished with, and I did it because you told me I could. And he said, so, can you tell me some more about that? And she pulled a permission card out and said, you told me I can make the change. But the problem we had was that we only had 80 people with permission cards. And there's only so much you can do to change a system of 16,000 people with 80. And invariably what you get in any large organisation or any large system is lots and lots of people all wanting to make a difference. But what they need is alignment. Right? So it's like herding cats. You've got lots of people doing really smart, clever things, but it's so much powerful if you line them up. So if you think about, if you had a table of iron filings, you threw it on the table and they're all going in different directions. What we decided we needed was a magnet to pass over those iron filings and to put them all in the same direction, to to be able to align enough people in the system with a vision that made sense and to point them all in one direction. So the issue we had was, how do you do that? Because you can't do it from a top-down approach. You can't just send an email from the CEO and say, change, because no one's going to. You can't send out black and white documents on A4 bits of paper that say change, because no one will do it. So we thought hard about how we'd do this. We developed this thing called Showcase. And what Showcase was a cross between a corporate roadshow, a vision or a mission document, and an interactive museum. You think of some of the best museums in the world you've been through. There's lots of displays that are interesting and relevant, and you tell stories about them afterwards. That was some of the inspiration we had when we designed Showcase, and I'm going to talk you through it. When people came, they had no idea what they were coming into. We took over a warehouse that had been disused for quite a while, and we transformed it. People walked in groups of 10 and came through to a waiting room where they sat down with their group of 10 and talked around while they were there. We sat them down and we said, make introductions. We ran it on a word-of-mouth system, so there was a host, and that host went out and asked other people, up to 10, to come along to Showcase. They sat down and we set up this room, and because of the lighting conditions, it's quite hard to show in a good photograph, but it looked a lot better than that in real life. And we purposely set it out with almost like a museum-type approach. Those chairs in that photo are from a nursing home that got demolished. Some of the photographs on the screen are deliberately taken from the archives of the hospital, and they talk around where things have come from. And what we found is that people started talking around, I recognise that ward or that person, and they recognised where things had come from. In the right-hand corner of the photograph is a series of suitcases. On those suitcases, we had them labelled with things like, that's not my job, we've always done it that way. What we said to people when they came in is, leave your baggage at the door. And it was fascinating that people actually looked at those suitcases and said, I heard that phrase 10 minutes before I came here. One guy said to me, someone said to me, we've always done it that way, 10 minutes before he came to Showcase. We took them through, and that rather ghostly apparition sitting in the middle of the screen is the CEO. We couldn't figure out a way to get key people there for the length of time we ran Showcase for, so we videoed them in full size and we projected them, so they gave messages. So they came into this waiting room first of all, and there are Zimmer frames there, the walking frames, and that's deliberate because one of the biggest pressures on the health system in Canterbury is an ageing population. So the first thing we did, we had them sitting down in Zimmer frames, listening to our CEO talk around some of the pressures on the health system. When that finished, you pushed through that door and you came through. It was very interactive, so someone actually could go through and push. And you came through into a room where we talked around systems around the world that have successfully managed to make large-scale transformation. And that was really important because people in health often feel like they can't make a difference. And even if they did, nothing would change. So the very first thing we did was said, actually, here's 5 health systems from around the world who have made successful large-scale change. And we had case studies. So people there reading the case studies about how that change happened. And then we said, so actually, if you could change, what would it look like? We spent a lot of time with clinicians working out scenarios for a particular patient, saying, what would things look like if you went forward? So we mapped out some points in time and said, what would it look like for a patient if nothing changed? And what would it look like if we managed to change the system? We did it for 2 particular conditions. We split the groups up for a very good reason. I'll explain later on. And they went through each of these rooms looking at scenarios for how it would look like for a patient. And then we brought it to life. We said, this is how it might look like in 2020. On the screen there is a simulated video conference call between a patient and her nurse. We gave the patient a name, Agnes. So Agnes was talking to her nurse, and what was interesting is that Agnes is about mid-70s. People came through and said, that would never work. Right? Someone that age would never use Skype. And actually, that woman does use Skype because her grandchildren are in different cities, and that is her real nurse. So we gave them a briefing and we said, how do you think things should look like in 2020, given the condition and given what you've got now and how you know where it should go to? And they ad-libbed. Had this really nice conversation about, care and remote conditions and how things should work going forward. We did that for 2 conditions, and this is a mock-up of a respiratory nurse's office. In Canterbury, the title respiratory nurse doesn't actually exist yet. So what we did, we mocked up what we thought a respiratory nurse's waiting room should look like. We mocked up her certificates, stuck them on the wall. We said this is what she'd have to do as a career path in order to become a respiratory nurse in 2020. And we sat down once again, but you'll notice that the screen's reversed, so it's now the patient's on the middle of the screen and the nurse is in the bottom left. If you use Skype, you sort of know what that means. And that wall, for example, that whole scene is a large-scale photograph. We're a bit constrained by space, so we went out to a general practice team and we photographed and blew up this image. We stuck a curvy wall on it to screw with the perspective. It was so effective that one person actually tried to put their notes on the desk by that printer, ended up punching their hand into the wall. It was very effective. Then we set people back and said, what is a health system? We're talking around systems, what does it mean? So the guy on the screen is a GP, and he's explaining about actually what does it mean to have a health system? Because lots of people working in health do not understand that they're working in a complex system. They look in their own little area and they see stuff coming in and going out, and they don't really understand what it means for interdependencies, for reliances, all those sorts of things, especially from a patient point of view. We had a graphical facilitator work up some conversations on the walls around there. You'll see large-scale diagrams and drawings. We captured conversations with senior leaders in the system talking about how the system would need to look in 2020 from different points of view. If you were someone working in the system, if you're a patient, what the infrastructure looked like. And the GP on the screen talked through those to bring them to life. We then took people through and said, what does it mean for you? And that's really important because it gives them all these insights and information, but we wanted them to internalise it. So what does it mean for you working in your part of the system? What needs to change? And we had this group discussion with people who would never normally meet because that was the way we got them there was through a mutual contact, and they may not know each other in the system anyway. And these fascinating conversations around how they should change and what needed to happen in the system. And they saw it from lots of different perspectives because hardly any group was homogenous. They were from all different parts of the system. We had some little pearls of gold come out of that. People actually drew entire system change diagrams. And one guy actually did it in such detail, I asked him, where did he get it from? He said, it just makes sense. And he just mapped it out on the wall and figured out how it would work. What we did also, after this was really important, we told stories of individuals who had made change in the system. Because people working in health feel like they cannot make a change. It's too big, it's too great. So we mapped out 4 stories of people who had made successful large-scale change. This is a nurse educator called Carrie Davies. What she did was she looked at how IV prescriptions were given in the system and how the training methods and documentation just didn't add up, didn't work properly, didn't give any more safety in the system than what it should have. So she's on the screen there talking around that. In the foreground, you'll notice something interesting, IV bags. So these are giant IV bags we had made up. They're about this big. And what we did, we printed the story on the IV bags. We wanted people to go through there and to resonate with whatever learning style they preferred. So behind that IV bag is a big white box. It's quite hard to read. Once again, lighting conditions we found hard to reproduce in photographs. But that big white box is an old X-ray box. And once again, we printed out the story on X-ray boxes because they're unused now in the system. So anybody going through Showcase could either resonate with what was being told in the video, or they could see the facts in black and white on the X-ray boxes about how the change was made and the quality results and the facts and figures, or they could read about it on the artefacts like the IV bags. Another story we told was about a surgeon who changed the way that gallbladder disease was treated. And what we had, once again, because you couldn't get the key people there all the time, we videoed them. It's quite hard to see in this, but actually on that big screen in the background is a head and shoulders of this guy called Saxon Connor talking around what it was like before he made these changes in the system. And the core of his story is about flow. So actually getting people to flow through the system really quickly and what it meant for people to be stuck in the system or bouncing back in and out where their gallbladder problems were diagnosed and treated and eventually dealt with. And so at the end of his video, he says, now to find out how things have changed, push the bed through the wall. And people stopped and thought about it, and we said to them, go on, push the bed through the wall. So they did, because it's around flow. Right? How do people flowing through a hospital? So they pushed the bed through the wall, and then there was Saxon on screen. You can see him this time. We mocked up a Keyhole operating theatre. We did have a whole suite of equipment in there with quite a lot of money, but it was required in the system later on, so we had to whip it out. We mocked this operating theatre up, and Saxon told the story of how things were different now, why it was different, and the significant change it made, not from a hospital perspective, but from a patient perspective. It's really important to bring it back to the patient. All the way through Showcase, we had to tell the story from a patient point of view, because it was the only commonality in the entire system is the people that come into the system to be treated. We told a couple of more stories as well. I won't go into many details. This is around a community program around healthy living and healthy lifestyles. We mocked up a general practice sort of lecture room. This is one around a before and after story of how skin lesions are treated. There were lots of stops in the system for patients. We mocked up stop signs. People had to push through them to get through the next part of the story. And then one of the key things around this was a web-based system called Health Pathways, which standardises care right across the system. When people had gone through these 4 stories, we stopped them and said, what are the key things that we would like you to think about in the system? Generally, there's this thing that people have around the world, the thing called the granny test. Right? So if your grandmother was in the system, how would you like her to be treated? And that's generally where that paradigm sort of stops. What we said to people is, that's not enough. Who else would you need to bring in to your granny test to provide an outstanding level of care? And then the third part of that is, if you weren't in the system at the time your grandmother came in, how would you turn that level of care into a process so it was repeatable time and time again? So it's not just about you being in the system. It's not just about you being in the system and making calls to people you know because you've been there so long you can make the right calls and pull the right strings. It's how do you turn it into a process that happens again and again. And the essence of it is this. We said to people, how can you make things better? Because at the end of the day, the CEO can only do so much, but this is around empowering individuals to make a significant change in the system. People came through in groups of 10, maybe 12 sometimes, but 10 was what we aimed for. And we had a debriefing session at the end because each group was unique. In the background, you can see a graphical recorder working there. If you haven't seen them work before, they essentially take conversations and magically turn them into a large-scale graphical drawing. And here's an example of how one of those looks like. For each group that came through Showcase, we gave them a capture of the conversation. The person who brought those 10 people through got the large-scale one, which is sort of yay big. Everybody else got an A3 colour copy of it. So on the spot, while they were having their conversations, we had a sort of a cut-off process where we took that image away, photographed it, reproduced it. So everybody who walked away from Showcase had a record of their conversation. And this is important because we wanted more conversations to start. So during Showcase, about a while into it, I walked around parts of the health system in Canterbury because people had told me that these things were appearing on walls and notice boards all around the health system. So here's an example at the bottom there, by that wash basin, there's 3 different groups of conversation appearing. Here on a corridor in the laboratories is a large scale, and there is some more sitting on notice boards around the system as well. And what we found is that people proudly displayed these, and they started conversations. So the people would walk past notice boards and they'd say, did you go to Showcase? What did you guys talk around? We talked about this. What does that mean for me? What does it mean for you? And they started conversations. And that's one of the really important things that we wanted to do, was for people to have conversations around their part in the system, the complexity in it, and the role they played in transforming it. At the end of Showcase, once the debriefing thing had happened, we said to them, so what do you think? What's the experience you've had? And we gave them some post-it notes and some pens and said, just write down your views. What we ended up with was something quite interesting, was a wall that looked like this. We didn't actually have a wide-angle lens useful enough to capture the entire wall. There are a large number of stickies on there. And when you look at them close up, you see some fascinating stories of the reaction that people had. And some of the themes up there were common right across 95% of the feedback we got. And the one that I really like is right in the middle there. Finally, a journey we want to take, and the map seems clearer, and above that, the last point, change is possible. So change is possible. These are from people who came through quite cynical, quite sort of disenfranchised about their role in the system, and not really understanding their part of it or the alignment or what the impact was if you waved the magnet across those iron filings and set 16,000 people off in the same direction. So if you're talking around evidence for how Showcase went, because health system runs on evidence, then this was a really interesting form of evidence for us, but it wasn't the only one. And also at the end of Showcase, what we said was that if you valued the experience and you thought other colleagues and peers might like to come along as well, you can be a host. And so we had a mechanism that enabled the word about Showcase to spread through peers, through colleagues, around coffee tables, water coolers, whatever. Because the power of Showcase was that there was no emails about it, there was no media release. The only way to get to Showcase was if somebody asked you. So bear in mind we started with 80 people, and we thought that a good measure of success would be maybe 40 of them might respond, and if 40 of those brought 10 people along, we'd have 400. We knew it took about 2 hours to go through Showcase with a group of 10. We thought we might run it for a week and a half. In the end, we ran it for 6 weeks, and we had 2,000 people come through. No email, no media coverage, nothing. The only way to get there was if somebody asked you. If somebody else thought that you would make a significant contribution to changing the health system, if they valued you as a thought leader or influencer, or if they thought that you were in a position to make a difference, you got invited. We had nothing to do with it. We didn't know anybody who was coming along. We knew the point of contact who had invited people, and we would liaise with them. And they would tell us, we think we've got 5 or 6 or 7 people coming along. On the day, it was always a bit of a raffle. Some people bought 14, some people bought 7, some bought 10. But we never knew how many were coming along until they actually showed up. That wasn't enough, though, because at the end of it, we had 2,000 people coming through, and we'd told them around it's possible to change, some stories of individuals who had made change possible. We told them around successful systems who had made change. We wanted more. We wanted to actually be able to say to them, if you have an appetite to make change happen, we'll teach you how to do that. So we started a night school program called Participate, which is essentially about 10, 15, 20 people going through a program which talks around theories of change, which talks around narratives. How do you tell your story? So what's really important with this stuff is that if you've got a kernel of an idea to how to make a change happen in the system, how do you enrol other people to make that happen? How do you get support? How do you get sponsorship? And once again, it's not through email and it's not through black and white documents. It's through telling stories. There are theories of change, but people who want to make changes at frontline don't know them. So we have set out to teach people how to make change happen. And this program runs alongside some of the similar themes that Bonnie was talking around clinical engagement, leadership, all those sorts of things. But we're aiming at frontline people. Running alongside that, you may see a theme in the branding, is a program called Generate. And what Generate is that it's really, really hard to get people to suggest ideas. If they have a really nice idea about how to make change happen, they can tell people, but how do you get it at scale? So what we implemented was is a web-based system, which is an idea management tool, and this is a screenshot from it. And the essence of the tool is that anybody can go onto the website, submit an idea, and anybody else can see it. They can comment on it, they can show their support, they can vote on it, they can form virtual teams. So this is a way of scaling one person's idea across 16,000 people. And as good ideas float to the top, because they get more visibility, they get cherry-picked off and evaluated for how possible it is to actually implement that, how much it would cost, and if it's viable. So you're using like a wisdom of the crowds approach to leverage one person's idea. When we started this about 6-7 months ago, went live with it, we thought it might, slow take up. We've got about 1,000 people enrolled in it now to 16,000, and it will start to get momentum a lot quicker now we've got critical mass behind it. Also, if you notice, the organisation that I work alongside is called the Canterbury District Health Board. You will not see a logo from that organisation anywhere in anything I've presented. And that is because politicians have a way of coming into public health systems and changing them. And what we've been really conscious of is actually whatever we do has to survive political changes. So there is no branding of the CDHB in that any of these programs whatsoever. And we've said it's around our health system. So if we go back, you will see our health system up there in both of those logos. There is no CDHB branding at all. The other thing that we've been fortunate enough is that if you're talking about politics and change, we started this program off in early 2007, and now we've had, so that CEO was in the photograph at the start, he has retired. We've had an interim CEO and a new CEO. We've had 3 changes of chairs and board, and we've been through 2 different boards. So this program is now so embedded in the system you couldn't take it out if you tried, and each time we see a change of governance coming along, we work really hard to ensure that there is continuation of this program. Now, that's around how we've worked to unleash some of the transformation. And one of the things that I wanted to do was run a little experiment before this presentation, and it was around word of mouth. So in about January, I sent an email out to 10 people as an experiment for word of mouth, asking them if they'd come along to the session. And I'm really curious, with a show of hands, if anybody's here who received that email. That's fascinating. And the reason that I think it's got to that point is because soon after I sent that email, there was a little distraction in Christchurch that you may have heard of in the form of an earthquake which devastated the city. And so my word of mouth campaign, which I'd hoped to kick off and put some more time in, got derailed on February 22nd when we had an earthquake which came through and caused widespread devastation. So one of the things I would like to ask today is a request for help. What we're faced with now is that we had a vision for 2020 of how things needed to change. It's now our vision for 2011. If you ever talked about a burning platform, we have one right now. We're in a position we need expertise around how to do rapid prototyping of processes. So how do you create processes that can make a difference really, really quickly? How do you rapid prototype facility design? We have an imperative to build new healthcare facilities very quickly to try and rebuild some of the capacity we've lost. And how do you go from disaster response to really reactively building a sustainable health system? So I'd love to hear from anybody who has ideas about that. I'll be hanging around afterwards down here, and I'd love to hear from them with any of those ideas. So thank you very much.
Roger, that's fantastic. And Bonnie. Right, time for some questions. We've got a few minutes before we need to go off to the plenary session. Who'd like to start? I'll bring the mic out to whoever'd like to kick off the questions. Can I see some hands? Yes, sir.
This question is for Bonnie. I'm Jim Robley from Ottawa. I've known Bonnie for a while. Bonnie, how did you incentivize the physicians to be engaged to the degree that you have in Saskatchewan?
Yeah, sure.
So far, very little. So certainly the learning opportunities, we've covered the costs of sending them on those opportunities. And with that investment, if you will, then the ask back is to, not dissimilar to what Roger was offering, is to how to then share it with colleagues and start to create broader communities. In the very early days of Health Quality Council, when we launched our improvement collaboratives, we did some cost offsetting for fee-for-service practices that were losing income. But interestingly, with the clinical practice redesign program, we have yet to hear from one practice that they want to be reimbursed for their time, that they are just very appreciative that we are now offering tools that will help them improve access and quality. So it hasn't been nearly as much as what it was in the early days. And so whether that changes, I don't know, but that's where it is right now. Very little.
Virtue is its own reward. That's the message. Okay. Next question. Rod? Yes, sir.
It's a question for Bonnie too, Carsten Engel from Denmark. I suppose your healthcare institutions are accredited. What are your reflections on the accreditation process as a tool in your toolbox?
Well, yes, definitely. Accreditation Canada plays a very big role in our health system. And what, again, we've seen, because Health Quality Council, my organization, works quite closely with Accreditation Canada in ensuring that there's better alignment with the accreditation process as well as the work that we're doing within the province. So to me, it's about the relationships that the organizations need to build to minimize the duplication or the redundancy that can sometimes happen when you've got improvement strategies and ambitions seeming to work at cross purposes. Are we perfect? No. But certainly the relationships that we have with organizations like Accreditation Canada, I think, is improving the experience and the outcomes of going through accreditation for the organizations in our health system.
Yes, this question is for Dr. Roger. Actually, it was a very interesting project, to change in the health system. What is the measures that you use to be sure that there is a changes or not?
So measures are fascinating for this stuff. So the measure of success for Showcase, first of all, was the number of people who came through. This is a quantitative measure. Qualitative, we see the qualitatively, that word. We can see some of the feedback that's coming through immediately afterwards. What we're seeing now is that the number of ideas that are going on to generate, a number of people who are enrolling and participate is one of the measures we're using of success. And also in terms of how people feel inspired around their ability to make change in the system is a really interesting, a non-quantitative example of how we can see that happening. People say that they can talk to others around a common perspective because they've been through Showcase. Some people want to go through Showcase again if we do another one. There's a whole suite of both evidence-based and anecdotal evidence around how successful it's been. A lot of it's around creating a platform, which we've got to carry on with now.
Hello, I'm Irene de Roy. I work at Christchurch Hospital, and I've been through the program. And I think what it has done as well is it has changed the culture of the organisation, awesome. And it has promoted the whole multidisciplinary approach, and staff do feel empowered. Thank you.
Excellent.
Well, on that note, as the next session's drawing near, I think we'll draw things to a close, but could we thank our speakers for a really, really interesting hour and a half? And I'm sure on everybody's behalf, all best wishes for colleagues in New Zealand, and if there's anything we can collectively do to help, we'd be really delighted to do so.
Thank you.
So what time do you leave?
About 4 o'clock.